Good morning and assalamu alaikum everyone. I'm Dr. Asif. Today we are going to discuss a little bit about peripheral vascular disease, mostly the clinical approach. Now firstly, let me tell you something that I'm not a vascular surgeon. I am just a general surgeon. So I hope my vascular colleagues would forgive me if I make some mistakes. What is happening for the last few days, a lot of doctors or students have been talking about peripheral vascular disease and their fear about peripheral vascular disease. I told them that I'm not a vascular surgeon, but what they want is the general surgeon's perspective of it, because at undergrad level, you don't have to have a very very advanced knowledge of vascular surgery. Just the simple cases that we see in our everyday life as a general surgeons and how to deal with them. So let me start. Okay, so what happens is first you have to take the history. History starts with the particulars of the patient. Now, what are the important points that's pertinent to a case of peripheral vascular disease? Age is always important in any case. Age, in case of peripheral vascular disease, it affects patients of all age groups. For example, if you're talking about Buerger's disease, I'm sure you have heard of it and you have seen many cases of Buerger's disease, and you'll see that it affects predominantly a younger generation, predominantly those who are below 35 years old. Another peripheral vascular disease may be Raynaud's disease, which predominantly affects the middle-aged population. And again, the diseases which are affected by atherosclerosis mostly affect elderly population. So age is very important. Age. Now, unfortunately, most of the patients that you'll see with peripheral vascular disease are male patients. Definitely female patients are also affected, but male patients are predominantly affected by the cardiovascular diseases. And in fact, in my life, I've seen virtually all of my patients with Buerger's disease were male. So male is definitely an important point. Occupation may be important. For example, those who have a very active lifestyle usually don't have a peripheral vascular disease. For example, athletes, they probably will never have any peripheral vascular disease, but those who are having a sedentary lifestyle for a very long time, for example, those who works in the office, who sits for a long time, they are more prone to have peripheral vascular disease. So those who have a sedentary lifestyle, it's particularly important that they may have this sort of disease. Chief complaints. Now, there can be many different complaints, but these are one of the commonest. So I'll just target these three. Number one, pain, usually in the limbs. Let's say right leg. There may be an ulcer. Patient also may say wound or something like that. Patient was, nowadays everybody can say what ulcer means. So the patient can't say ulcer, although it's a medical term. I think you can use ulcer in chief complaint. I don't think anybody would mind about it. And another one is blackish discoloration. Blackish discoloration of a particular, maybe the grade 2, or maybe a whole limb, something like that. This is sort of a format. How would you like to write about the history of present illness? Now, I always remind you that it is personalized, it's individualized. You can always have your own way of writing it. You can always say that I did not like this part of it. But what is important is it should be short and it should have the information that is necessary to make the diagnosis. So this is my way of writing a case of peripheral vascular disease. Let's see what I wrote. According to the statement of the patient, he was reasonably well about 5 months back. Then he developed pain in his left leg meaning the left calf muscles, which the pain has gradual onset, which was cramping in nature, moderate in intensity, non-radiating. Now, this is the important part, which starts after walking about 500 meters. Now, remember, this pain was not there when the patient took the first step. It was not there, but it gradually started when the patient walked round about half a kilometer. This is the distance which takes for the pain to start is called claudication distance. The pain aggravates if he continues walking. This is very important. The pain aggravates if he continues walking. Only relieved after a few minutes of rest. That means the pain, when the patient stops walking, takes rest, then the pain is relieved. Now, over the last 5 months, the pain increased in intensity. Previously, it was moderate. Now it is severe in intensity. The walking distance is now also reducing, meaning the patient previously was, maybe the claudication distance was 500 meters. Now it's reduced to 400, 300, maybe 100 meters now. Now the patient can only walk around about 100 meters when he has to take rest due to severe leg pain. The pain now has, intensity of the pain has also increased from moderate to severe. For the last 1 month, the patient is having a pain in the right foot. It should be right leg. I think it's better you write it right leg also. It can be right leg as well. Depends on where the pain is. Even at rest. Now, this is important. The patient now, the pain starts even at rest. The patient is not walking. At rest, the pain is starting, which is a sign of severe ischemia or sometimes maybe critical ischemia, which wakes the patient at night. This is particularly important. Many a times the patient would tell you that the pain is sometimes severe that it doesn't allow him to sleep at night, or the pain is moderate before sleeping but increases in intensity at night when he sleeps. There may be, because during sleeping the heart rate reduces, the blood pressure reduces. As a result, the vascularity of those particular areas, the perfusion also reduces, which results into the severe pain. Now, how is it relieved? Relieved by hanging the leg by the side of the bed. The probable cause of this is gravity, I think. When the gravity pulls the blood down, and as a result, the patient gets some relief. You should also add, at this point, you should also add, if you have any other findings related to other systems, like cardiovascular system, respiratory system, cerebrovascular, neurovascular systems, and also the other limbs. May have tingling, numbness, and weakness. So I'm coming to that. Oh, this particular thing I wanted to talk to you about is where this term claudication came from. It probably came from the emperor, the Roman emperor Tiberius Claudius. Now you can see the emperor here is on his knees. The emperor wasn't able to walk properly. He used to limp, and from that, the claudication, this term came. Claudication, that means I limp. Now, some people say that this was actually fake. He was able to walk, but he liked that people used to underestimate him when he was limping. So by showing this fake limp, he rose to the position of a Roman emperor, and he ultimately, one of the few Roman emperors who ultimately had a natural death. And most of them died in war or killed by their own families or their own friends or even by the army. But this is one guy who lived his life and ultimately died of natural causes. So we don't know that's fake or real, but this is the story of Emperor Tiberius Claudius, from whom the word claudication came. Okay, let's get back to business. The past history, very important. As I have been talking about the cardiovascular, if you now take the history of cardiovascular disease, what I do is usually I ask the patient that can you apni ki shiri diye uthte paren tin tala char tala. If the patient says yes, then I think the patient is healthy. Most of the patients say na uthte pari na. What happens? Maybe chest pain, maybe palpitation, বুক ধরফর করে। পেশেন্টরা খুব কমনলি এটা বলবে, আপনাকে দেখবেন যে স্যার ৩-৪ তলা সিঁড়ি দিয়ে ওঠার পরে প্রচন্ড বুক ধরফর করে, ঘাম হয়, অনেকে বলে শ্বাস বের হয়ে যাচ্ছে, মানে ইজ ডিফিকাল্ট, রেসপিরেটরি ডিস্ট্রেস হয়। So history of cardiovascular disease, you must take. Cerebrovascular disease, meaning cerebrovascular disease, syncope, loss of consciousness, blurring of vision. These are some of the features of cerebrovascular disease. History of importance. Why this is important? when the patient has peripheral vascular disease, the patient may also have central vascular disease. That means the vessels within the trunk may be affected, right? So if the internal iliac arteries or the iliac arteries are affected, the vessels which supplies these places may also get affected. So it may result into impotence. Abdominal pain, the mesenteric vasculature may be affected, which results into chronic mesenteric vascular occlusion. When the patient says, "Sir, আমার খাওয়ার একটু পরেই পেটে ব্যথা শুরু হয়." Of course, it can be gastric pain, but must check whether the patient has mesenteric vascular occlusion or not. Okay, then the previous hospitalization, surgeries, medications, you must all take this history. This is part of your general history taking. Smoking, most important. In any case of peripheral vascular disease, cardiovascular disease, cerebral, anything related to vessels, smoking is most important. Smoking in Bangladesh, a lot of people take bidi, which is even worse than the smokes that we take because they are usually unfiltered. When did he start? How long? How long has he been smoking? 10 years, 20 years, 30 years? How many packs per day? How many packs per day? If stopped, when? I mean, people would say, you'll go to the patient with peripheral vascular disease, you'll ask the patient, আপনি সিগারেট খান? সে বলে, হ্যাঁ স্যার খাইতাম, আগে খাইতাম। এখন কি এখন খাচ্ছেন? না স্যার, বন্ধ করে দিছি। When you ask the question when, the patient will sometimes say, স্যার 1 মাস আগে, 2 দিন আগে। Some would even say, স্যার আজকে সকাল থেকে। This is what happens. So it's very important. Just don't take it for granted the patient has stopped smoking. The patient will say something like that. Now you should say another thing, that pack year. Pack year. You don't have to know it, but pack year is something some of the especially the foreign examiners like this thing. They'll ask you, what do you mean by pack year? For example, if I say one pack year means one pack per day for 1 year. One pack per day for 1 year. One pack means 20 cigarettes. Usually in a pack of smokes, there are 20 cigarettes. So the patient has been taking 20 cigarettes per day for 1 year. That means 20 into 365. Then you can have an idea of how many cigarettes he has been smoking. Now, what is the importance of this? Importance of this is, in many of the literature, they say if the patient has 40 pack years, that means the patient has probably been taking one pack of cigarettes for 40 years. Maybe. Now, if this is the number, and this is a high risk, this patient's a high risk for pulmonary malignancies or lung cancers. Alcohol, definitely you'll have to take the history of alcohol. All diseases are one way or the other related to alcohol and smoking. Cardiovascular disease, I've talked about it. Family history also must take family, how many children the patient has. Because if you remember, I've been talking about impotence. So if the patient has been having this vascular disease for a long time, the patient may be impotent. So must take the history of his family, his own family, and his parents, his brothers and sisters, anybody suffering from similar illnesses. Drug history. Drug history is a very drug history will give you an idea of what are the drugs the patient has been taking. For example, whether the patient has diabetes, whether the patient has hypertension. These are all hypertension, diabetes, lipid profile. I mean the hyperlipidemia. So all these diseases are predisposing to peripheral vascular disease. Any surgeries he had, very important. Take the history of surgeries. Socioeconomic status, all these 3 groups of people may be affected by peripheral vascular disease. Usually, upper class people, they are affected by atherosclerosis. Poor people, they are affected by Barger's disease. you'll see that the Barger's disease are very common. You'll go to a government hospital, you'll go to the wards, you'll go outside the ward, and you'll see a lot of people with amputated foots, blackening, or with Barger's disease. They're all very poor people. They are always it's mostly the number one cause of this is the cigarettes or the biri that they have been taking. So this is very, very important. Take this history. Immunization history, part of the general history, you can take it. General examination. What are the important points? Nutritional status. The patient may have a high BMI or low BMI. High BMI or obese people might give you an idea that the patient may have hypercholesterolemia, maybe has an atherosclerotic disease. Pulse, most important. For general examination, take the radial pulse. And when you go to the systemic examination, you take the pulse of all the major vessels. We must record the rate, the rhythm, the character, the condition of the vessel wall. These are very important. Blood pressure, whether the patient is hypertensive or not. Anemia, particularly important. Edema sometimes may be present. Check it. Lymph nodes, if the patient has a ulcer in the leg, if the patient has a gangrene at the foot, you must check about the inguinal lymph nodes. Dehydration may or may not be present. Blackish discoloration, very important, very important. Why is it important? Local examination, most important. When we are doing the local examination of the limbs, now this is the difficult part. Most of you have a confusion of how to do the local examination. Local examination, like all other examinations, starts with inspection. When we inspect, what do we see here? This is pretty much the way you will see in your daily in your hospitals as well. You'll probably see an area of blackish discoloration. You must mark where it starts, where it ends. Does it have a well demarcation, or does it have a poor line of demarcation? Is it foul smelling? Is it dry, shriveled, or is it edematous? Is there any sensation? Is there any sensation? Can the patient move the affected limbs or not? These are very important. Look at the skin of this patient. If you look at the skin, you'll see it is dry, slow quality, it's lusterless. If you look at the skin, there's no hair over here, loss of hair. Subcutaneous fat is lacking. So these are the things. Remember, when you look at the skin first, you look at the skin, what do you see? It's dry, it's thin, it's shriveled, it's lacks any hair. Subcutaneous fat is lacking. You look at the nails. The nails are brittle. Nails are brittle. You can see a blackish area. What is this blackish area? This is an area of gangrene. What type of, if just looking at it, you can see it looks dry. It looks shriveled. And if you smell, you'll see there's no smell. There's no sensation over here. This is a dry gangrene. Again, over here, this is dry gangrene. What else would you see? You'll see venous guttering. If you look at this area, look at this area over here, and look at this area over here. There's a vein over here, right? You can't see the vein. It is guttered over here. Why is that? This is because there was a vein over here which would have been filled had the patient have a good arterial supply. When the arterial supply would pass back through the veins, but the arterial supply is deficient. As a result, there's less blood in the veins. That's why there is a venous guttering. This is called venous guttering. I've seen a lot of students in the final probe asked about what do you mean by venous guttering. They could not say. This is venous guttering. This is why it is there. It's because the veins are not filled with blood, as because the artery cannot supply enough blood. This is called venous guttering. Again, you see another area of gangrene. This is blackish discoloration. This is dry, shriveled. It's a very good line of demarcation. You can see where it starts, where it ends. If you ask the patient, do you feel any pain? The patient can sense nothing, no sensation. In case of a wet gangrene, there will be pain. No edema. no edema. It's dry. The patient won't be able to move the fingers. These are the few things that you'll have to see. This is very important. Over and over again, this will be asked to you in your final prop, maybe in the clinicals as well. You must be able to describe a gangrenous part of the body. Very, very important. Again, another sign of dry gangrene you can see. The line of demarcation is most important. This is the thing which you must see. This is a definitive sign that this is a dry gangrene, dry shriveled area. Now, this is a wet gangrene. If you look at it, it doesn't have look. He has a very good demarcation, line of demarcation, but there is no line of demarcation. Where it starts, where it stops. Is it here? Is it here? Is it here? You have no idea. It's edematous. Look at the edema over here. There is a lot of pain over here. If you ask the patient, there will be pain. Foul smelling. There will be a foul smelling discharge. There may be foul smelling discharge. Patient may have fever. Patient may even also be able to move the limb. But what are the difference? Difference is the line of demarcation. There is a good line of demarcation. There's a poor line of demarcation. It's edematous. It's edematous. There will be pain. There will be pain in case of a wet gangrene. There may be fever even. Why? Because here there's some sort of infection going on. But here's no infection really. If you leave it over here for a couple of days, it will ultimately separate from the body, and there will be auto amputation. In case of a dry gangrene, there will be auto amputation. But in case of wet gangrene, you must act. Something has to be done in this case because this will spread. This will spread. So this is very important. You must give antibiotic. Amputation may be necessary. Immediate amputation may be necessary. So this is important. Must act over here. In case of dry gangrene, even if you leave it as it is, it should not spread. And there's a chance that ultimately it will separate by auto amputation. Okay, let's leave this. Another thing, there's ulceration. This is very, very important. I'm sure each and every one of you will get one ulcer in your final prof, one way or the other. So ulcer, very important. How to examine an ulcer? How to examine an ulcer? The most important thing first, start with the site. Look at the site. Look at the site over here. The site is the sole of the foot in and around the pressure area. If you ask the patient, do you have diabetes? The patient will say, yes, I have diabetes. Usually this patient they're having this ulcer for a long time, for 2 to 3 months or even more. Patient is having uncontrolled diabetes. This is a diabetic ulcer. Usually happens in and around pressure areas. Diabetic ulcer. Or another term for it is neuropathic ulcer. Look at this ulcer. This is in and around just above the malleolus. This is called the gaiters area. The gaiters area. This is another vascular ulcer, but this is a venous ulcer. If you check the limb, patient's limb, you may get varicose veins. Look at the color over here. Pigmentation. It's called hemosiderinosis. Now this one, the one we are discussing today. At the tip of the toe, there is a circular ulcer at the tip of the toe. This is a very diagnostic of a vascular ulcer. Look at the dark area. If you check the pulse over here, you probably won't get any pulse for this patient. This is a vascular ulcer. Sorry, this is a vascular, this is an arterial ulcer. Arterial ulcers are also called punched out ulcers. At its base, you will see usually they are deep ulcers, and you'll see the skin. There usually is no granulation tissue over here, and usually they are very painful, very painful. There is no pain over here. This is a neuropathic ulcer, no pain. Usually there is no much pain over here as well. But vascular ulcer, pain. Important feature. There will be pain. It's a painful ulcers. Okay. This is a case you'll see that the chronic. This is actually a case patient has been. We have done a Burgers test in this patient. I'll come to you with Burgers test means. Burgers test means you raise the leg of a patient to around about 30-40 degrees, and you'll see. If you look at this, on this side, it's not pale, but on this side, there's pale. The same patient, pale. This is because of lack of vascularity over here. Very good picture. Also, very important, most of the times, the SAR will not, in your final prop, the examiner will not let you touch the ulcers. What they will ask that, just tell me what you see. Just tell me what you see. And many a times you will see this, the loss of a toe or amputation of a part. What happens is, during inspection, you forget to tell it. And SAR says, what else, what else, what else? And you don't see, we are thinking, what else is there? But amputation. This is very important. Don't miss it. Don't miss it. Okay. What are the things? This patient may have muscle wasting. This is actually part of the palpation. Muscle wasting is another very, very important part. If you look at the muscles, you must be able to compare the muscle. How to measure muscle wasting? Just take a particular area, for example, the the tuberosity over here, and from here, let's say take about 10 centimeters on both sides, 10 centimeters, and measure the muscle over here and compare them. So what you have to measure the muscle wasting or to compare the muscle bulk, you have to take a particular bony prominence on both limbs, and from there take a constant distance and then measure the muscle in that same area. That's it. Very simple. Very simple. This is the way you have to do it. Look at this. Have a measuring tape with you at all times, because you think that you will be able to do it in the exam, but in the exam you make it very messy, and the SAR understand that you have never done it before. So always get any chance, measure the muscle bulk of the patients. Very important. Okay, sorry. The palpation definitely starts with the temperature. This is very important. I'll tell you, when you start, in case of vascular case, just palpating the temperature will tell you that there is a vascular insufficiency. Definitely, if a particular limb has less vascularity than the other, the temperature will fall on that particular area. So measure the temperature. Go from below to above or above to below. There is not really a big problem, but make sure you compare them. It's very important. Capillary refill. You press on the nail bed for around about 2 to 3 seconds and then let it go. Usually it is filled immediately, but if it takes more than that, then we say that the capillary refill time is longer. Usually it is less than 2 seconds. You can check it on in your own fingers. Very simple test, but a very, very good test. Because what happens is sometimes that there's so much edema, it's very difficult for you to palpate for the vessels, and you're confused. But this is a very, very good test. Capillary refill. This will always give you a good idea about the vascularity of the limbs. Whenever you are giving a case, I think almost all of us had to palpate for this artery, Arteria dorsalis pedis. Very, very important artery. What are the things you must, because the SAR will never know whether you can palpate it or not, but the SAR will ask you what are the points, how do you localize it, how did you localize it? It is in the first intermetatarsal space, just lateral to the tendon of the extensor hallucis longus, and you palpate it against the navicular bone. The navicular bone is over here. So remember this. Most of you make a mistake and try to palpate it over here. No, there is no bone over here. Remember, you need to have something to press on to palpate something, right? So here's nothing, just a space filled with muscles. So you need the navicular bone, the navicular bone. So what is the position of the arteria dorsalis pedis? It is in the first intermetatarsal space, just lateral to the tendon of the extensor hallucis longus against the navicular bone. Very important. And remember, you need to have the watch. Whenever you're trying to palpate a vessel, try to show that you are looking at the watch as well. Okay. Anterior tibial artery, where it is? Just in the midpoint between the two medial and lateral malleolus against the tibia. The posterior tibial artery. The posterior tibial artery. Where is it? First, you have to invert the foot a bit to relax the flexor retinaculum over here. The flexor retinaculum is somewhere over here. Relax it and then palpate for the posterior tibial artery. Where is it? The posterior tibial artery, if it is the medial malleolus, if this is the medial malleolus and this is the tendoachilles at the midpoint, or it can be the medial malleolus and the insertion of the tendoachilles, this is 1/3 at this point, because the vessel goes like this. Vessel goes like this. So it is, if it is the midpoint between the medial malleolus and the tendoachilles, or 1/3 the way between the medial malleolus and the insertion of the tendoachilles in the heel. Then comes the popliteal artery. Popliteal artery, I will agree that the popliteal artery, palpating the popliteal artery is quite difficult. Even we all had difficulties palpating the popliteal artery. There are various ways of palpating the popliteal artery, in the prone position, in the supine position, but this is the most accepted way. This is the position, and it is palpated against, again, the tibia. The tibial bone is over here, and you can palpate it. It takes a lot of practice, but don't embarrass yourself. It's just, if you cannot palpate it, it's not a very big problem, because many of us are having difficulty palpating it, especially in a bulky patient. It's quite difficult to palpate the popliteal artery. And remember, if it is very easily palpable, then there is a chance there is a disease like popliteal artery aneurysm. So make sure. This is the way to put your hands like this and press it hard, and then you might be able to palpate it. If you can't palpate it like that, you can also do it in a prone position. There are all videos over there. You can just check it, have a look at it. It's the different ways. But main thing is, what you need to do is practice. A lot of practice is necessary, especially to palpate the popliteal artery. Femoral artery palpation is very simple. Where is the femoral artery? It's the midpoint of the mid-inguinal point. There are two things: midpoint of the inguinal ligament and the mid-inguinal point. What is the midpoint of the inguinal ligament? Inguinal ligament start from the anterior superior iliac spine and in the pubic tubercle. And the mid-inguinal point is a midpoint between the anterior superior iliac spine and pubic symphysis. So the mid-inguinal point is somewhere over here, and midpoint of the inguinal ligament is somewhere over here, and the deep inguinal ring is somewhere over here, and the femoral artery is somewhere over here. So this is actually femoral artery palpation of the femoral artery is quite simple. I have never really failed to palpate it. I think you'll be able to palpate it very easily as well. Just make sure to say it's mid-inguinal point, not midpoint of the inguinal ligament. Okay. Berger's test. This is another test. Actually, what happens is, nowadays we have the handheld Doppler, and we do not need so many tests to do. But again, for theoretical purposes, you have to know this. What happens is, in Berger's test, we try to elevate the lower limb. For example, let's say at first at this level, which would be something like 20 degrees. Then wait for a minute or two and see if there's any pallor. If not, then again elevate it to, let's say, 30 degrees. And then like this. If, in fact, in a normal patient, there should not be any pallor, even if it is 90 degrees. But in case of a patient with peripheral vascular disease, you may get pallor at a lower angle. If the angle is less than 30 degrees, that means critical ischemia. This is Barger's, a very, very simple test, very simple test. Make sure that you don't make the mistake of not palpating the inguinal ligament. You must palpate the inguinal ligament. This is very important, because many a times the SAR would ask, if you have an ulcer over the foot, SAR would ask, what else would you like to do? Must palpate the inguinal ligament. Any ulcer in any part of the body, do not forget to palpate the draining lymph nodes. Other systems, again, the cardiovascular system, respiratory system, the cerebrovascular system you have to do as well. Abdomen, whether it's abdominal pain or not, spine, these are the systemic examinations you have to do as well. Make sure you do, and you must take the, you must examine all the vein, all the arteries, sorry. What you have to do is make a chart like this. Maybe this is right, this is left. And here is the name of the artery. For example, let's say the femoral artery over here. Femoral artery. You can say something like, if it's palpable, you can say plus. If it is slightly palpable, you can say plus minus. Or if it is not palpable, you can say minus. Something like this. And you write about all of them, femoral, popliteal, and all other arteries, both upper limbs and lower limbs. In a case of a peripheral vascular disease patient, you must palpate all the named arteries. For example, in the hand, the radial artery, the ulnar artery, the brachial artery, the axillary artery, and these are all the arteries of the limbs. Okay, after that we come to the salient feature. It may be something like that. Mr. X, 27 years, a day laborer from Borishal, was admitted with the complaints of intermittent claudication in the calf muscles for 5 months, wrist pain in the same area for 2 months, and blackening of the left grade 2 for 10 days. He is non-hypertensive, non-diabetic. May have hypertension, may have diabetes. For 4 years, I'm sorry, this is not needed. This is wrong. Okay. Non-hypertensive, non-diabetic, and a smoker for 15 years. Very important. A smoker for 15 years. His pulse is normal, blood pressure. He is with medication. If the patient, make sure, if the blood pressure is normal, make sure you ask the patient, are you taking any medications or not? Very, very important. Only the femoral pulse is palpable, and other pulses are not palpable. And he has a dry gangrene in the left grade 2. So this is the thing. The salient feature, always make sure the salient feature, to make the salient feature as short as possible, but pack as much information as possible in it. This is the best thing. Don't make it too lengthy. I would say for a salient feature, try to write it within 5 or 6 sentences. That's it, not more than that. Provisional diagnosis. Provisional, certainly can write the provisional diagnosis in different ways, but this is where usually what I write. Peripheral vascular disease involving left lower limbs with ischemic gangrene of left grade 2. If you know what the main cause is, then you can write due to Barger's disease. Maybe you can write due to Barger's disease. It can be if it's a young patient, maybe Barger's disease, elderly, atherosclerosis, middle-aged, Raynaud's disease. Other diseases may be present as well, right? Rheumatoid arthritis, SLE, in which case it would be Raynaud's phenomenon. If Raynaud's disease is the primary, if the Raynaud's disease, what is the difference between the Raynaud's disease and Raynaud's phenomenon? What happens in Raynaud's disease? What happens is there is usually intense vasoconstriction of the vessels when there is change in temperature, usually when it's affected by cold. So if that is the primary disease, it is called Raynaud's disease. Raynaud's disease. And if it is due to a secondary to some other disease, then it's called Raynaud's phenomenon. I think you're a little confused. Let me go back again. What happens is, if you cannot find any other disease with which it is related, this color change or this intense vasoconstriction of the hands or the foot, if it is the primary disease and the only disease, then it is called the Raynaud's disease. But if it is secondary, I mean, that is due to some other disease, this phenomenon is happening to a particular other disease, like rheumatoid arthritis or SLE, then we do not say it is Raynaud's disease, then we say Raynaud's phenomenon. If it is primary, it is Raynaud's disease. If it is secondary, it is Raynaud's phenomenon. If we get another chance, we will discuss this in further details in a future lecture. Now, investigations, what do we do? Most important, if you're a vascular surgeon, if you do a vascular examination, it is very good if you can have a handheld Doppler. This is the best piece of instrument I think you can have. Even if you're not a vascular surgeon, I think you should have it. You can buy it. It's a little bit expensive, but I think you should have it. It's quite important to be able to measure, able to take the pulses. And ankle brachial pressure index. What does it mean? You measure the ankle pressure, then you measure the brachial pressure, and then you divide the ankle pressure by the brachial pressure, and the ratio is usually 1. Normally it should be 1. For most of us, it is 1. If it is less than 1, for example, 0.5 to 0.9, that means it is mild obstructive change. If it is somewhere between 0.5 to 0.3, that means severe ischemia. If it is less than 3, that means it is critical ischemia. Very good test. You must do this. If you have a Doppler, handheld Doppler, it is quite easy to do this. Even handheld Doppler is not there, even then you can do it. It's not a big problem. Duplex imaging, the most important investigation in case of a vascular case. You must be able to do this. Not you. I mean, you must send a patient to a vascular surgeon or for assessment in case for duplex imaging. What is this? Duplex means, that means you can understand something to do with two. Two things are done over here. What are the two things? Number one, there's a B mode ultrasound and Doppler study. With the B mode ultrasound, you can understand, you can check the vessel, image of the vessel. You can image the vessels, how much of the vessel is obstructed for the B mode ultrasound. And Doppler study uses the Doppler shift. Doppler shift means when something is flowing towards you, if you send a sound towards it, initially, let's say this is the sound, and there will be a reflected sound, right? Something which would be something like this. And the difference in the frequency between this sound and this sound, there will be a difference in frequency, because when this is going over here and coming back, the frequency usually increases. And the difference is called the Doppler shift. With this, you can measure the speed at which something is coming to you. Doppler shift. I'm sure you have studied this in class 10 physics. So that's the thing. The site, the extent, the severity of the blocks, most importantly, the collaterals can also be found over here. Angiography. It's a very good investigation. Nowadays, it's not done as much as the duplex, but it should be done as well. If you look at this, the femoral artery over here, in this case, there is no flow over here. And here there is a flow. Very good test to check. If you do any surgery, it is a test that has to be done. And you can look at over here, there are a lot of collaterals over here. This is a very good investigation to check for collaterals as well. Here, less collaterals. Here, more collaterals. Other investigations, blood test has to be done, the hemoglobin level, blood sugar, whether the patient is diabetic, lipid profile, other tests. For example, what else we need to do? For example, you have to check for serum creatinine. Make sure you do one of these tests. As you know, the vessel, all vessels can be affected. The abdominal vessels may be affected, mesenteric vascular occlusions. The cerebrovascular, the vessels in your brain, the carotid arteries may be affected. The intercranial arteries may be affected. So must take history, and if there is any positive finding over there, must do the investigations as well. If the patient may have a kidney problem as well, because the renal arteries may be affected, do a serum creatinine as well. The patient would be taking long-term drugs, do a serum creatinine, make sure that the patient has a good kidney function. Treatment. So what are the treatments? Now, in case of all vascular problems, the number of treatment is smoking. Stop it. Stop smoking. Absolutely, you must stop. In case of Buerger's disease, I think if there's only one treatment in Buerger's disease, stop smoking. Because you know what happens in Buerger's disease, if the particular vessel is over here, and let's say this particular vessel is blocked, this particular vessel is diseased in a Buerger's disease. What happens in Buerger's disease, the medium and small sized vessels are affected. So what happens? All the vessels distal are affected, it's blocked. So it creates a lot of collaterals. See, a lot of collaterals are created. Now, if you keep on smoking, even these collaterals will also go away. So it's very important that you advise the patient that absolute cessation of smoking if you want to keep the limbs. If you don't want to keep the limb, if you amputate it, then it's okay, then keep on smoking. But if you want to keep the limb, this is the only chance of survival. So, in fact, in any case, even in case of atherosclerosis, smoking is a big problem because smoking creates a lot of chemicals which affects the intima of the vessel, and the intima becomes diseased, inflamed. Control of comorbidities. If the patient has hypertension, if the patient have diabetes, must control it. If the patient has hyperlipidemia, must get it down. Exercise, very, very important. Unfortunately, in our country, exercise is not something that we commonly do. Even if you ask the patient to do some exercise, patients sometimes say, "Sir, give us some drugs." Nobody wants to do exercise. Ask the patient to do at least 1 hour of walking every day. If he wants to do something more, it's okay, but at least 1 hour of walking every day. Drugs are mainly not always effective, but we always give drugs, usually vasodilators like pentoxifylline, cilostazol. All of them, what they do is they reduce inflammation, increase the diameter of the vessels, and increase the vascularity. That's what they do. If there's severe pain, analgesics, aspirin, sometimes we use. Most of the drugs, what are they doing? They act on the collateral vessels. That's how they increase the vascularity. Buerger's exercise, very important. In case of Buerger's, this is what we ask the patient is do regular graded exercises. We ask the patient to walk maybe 50 meters one day and keep it for 7 days. Maybe on the 8th day, the patient would be able to walk another few feet. And this is how they increase their collateral circulations. This is how they increase the collateral circulation. Remember, in case of Buerger's disease, the whole aim of the treatment is the collaterals, because it is an irreversible disease. The vessels which are gone. So what we are trying to do is improve the circulation by treating the collateral circulation. So ask the patient to walk each day. It's graded exercise. Maybe the first day 100 meters. Then after 1 month, maybe 110 meters, something like that. Increase the distance. Care of the feet, care of the foot, very important. The patient has diabetic, must take care of the foot. You don't want to have another infection over here. Proper footwear, make sure it's comfortable for the patient to walk with whatever he is wearing. Give him a proper footwear. Surgery. Now, remember, in case of Buerger's disease, as you know, the distal vasculature is all affected. So surgery is not going to improve anything. These vessels are all gone. So most of the time we concentrate on the collaterals, but another thing that we do is lumbar sympathectomy. This is for theoretical purposes. In my life, I have seen 2 lumbar sympathectomy, and that's it. I have not seen, for last many years, I haven't seen any lumbar sympathectomy, but it's still done. Why is it done? You know what happens is in case of the lumbar what happens, the sympathetic nervous system causes vasoconstriction. So what we are trying to do is we are trying to remove the sympathetic nervous system supplying a particular area. For example, in here, the lumbar usually 2, 3, 4, or 1, 2, 3, 4, something like that. You remove the sympathetic ganglia, 2, 3, 4, something like this. If you're doing bilaterally, they'll at least skip one, because otherwise the patient may have impotence. So if you're doing bilaterally, then on one side all four, and another side just 2, 3, 4, maybe something like this. This is again, I'm telling you that we do not do this nowadays because it is not very helpful, but we do it. You must understand the theory behind it, because if you remove the sympathetic supply over a vessel, the chances are more that there will be some vasodilatation, right? There will be some vasodilatation. That's it. That's why we are doing this. Omentoplasty, profundoplasty. I haven't seen those surgeries, but they are written in the books. Have a look at this. What omentoplasty is done, the greater omentum is brought down into the leg. Somehow it increases the vascularity, which is, I have never seen this surgery. Profundoplasty, probably they are doing this. Profundoplasty is something, it's just the profunda femoris artery. It is increased in size. For example, let me just show you. If let's say this is the profunda femoris artery, right? What we are doing is over here, we're cutting it and attaching a let's say artificial graft over here. As a result, the profunda femoris artery becomes thick, wider in lumen, something like this. I'm sure our vascular colleagues will give you a better idea. You can see a lot of surgery videos over there. But the thing is that to increase the diameter of the profunda femoris artery. And lastly, if nothing happens, amputation, which is the commonest thing that is happening in case of Barger's disease that we see all the time. In case of arterial occlusion, because if the patient has arterial occlusion, something other than Barger's disease, then surgery has some role. Then we can do something with the surgeons. For example, balloon angioplasty. What you can see is over here that it's very thin. There's an atheroma. Use the balloon and increase the diameter over here. Balloon angioplasty. This is called balloon angioplasty, or dilatation using a balloon. What else is there? Stent. Usually after doing a balloon angioplasty, to make it permanent, we use a stent. As you can see, a stent is placed over here. You can see the stent. This is how we dilate a narrow area. Atherectomy, these are special devices which removes the atheroma in a vessel. Thrombectomy. What is done over here? If there is a thrombosis, a thrombus may be removed. Sometimes surgically, thrombolysis is another thing that also we do. Thrombolysis. What is this? We use some sort of chemicals. We insert this chemical. If say, let's say this is a thrombus formation over here. We took a catheter over here and we used a chemical to dissolve this thrombus. This is thrombolysis. Remember, thrombolysis has to be done quite early. I mean, if you do it maybe 1 month after a thrombus is formed, it's not going to work. It has to be done within hours, I think. Endarterectomy. Now, what is this? Another surgery that is called endarterectomy. This is commonly done in, I have seen this surgery done on a carotid artery. What is done over here? If this is a carotid artery, and if a plaque has formed, if you just remove the plaque like this, you see in all these cases the plaque is always staying there. So there's a high chance that again something is going to form over here, right? This is because the intima are diseased. The intima, you know, the internal layer of the vessels, that layer is diseased. So what is done in case of an endarterectomy is the plaque together with the intima is removed. Even the intima is also removed. That's why it's called endarterectomy. You see that this part, the intima has been removed from that, because if you keep the intima over here, there's a chance that again the disease may occur. So removing the intima, this is commonly done in many vessels, but I have seen in case of carotid artery. You can see a lot of videos over there. Vascular grafts, commonly done nowadays. The vascular grafts. Vascular grafts are usually two types of grafts we use. The two types, natural and synthetic. Natural and synthetic. What do you mean by natural? Natural means our arteries and veins. For example, what the vein, the commonly used vein is the saphenous vein. The great saphenous vein is being used. You can see over here, the saphenous vein. And arteries, for example, over here, you can see the internal mammary artery is being used. You can see both the great saphenous vein being used and the internal mammary artery. And then comes the synthetic ones. The synthetic, we use PTFE, different Dacron, different chemicals that are being used, which make up which looks something like the vessels. And you use the synthetic. Most of them, what happens is, for example, if the patient has something like aortic aneurysm, because you don't have a vessel something like that big. Because, for example, in this case, you look at this, here the femoral artery is occluded. So we are using the great saphenous vein. I know that the saphenous vein is not as big as the femoral artery, but it is comparable. It's something, let's say, 40% of the size of the femoral artery maybe. So it will work something. But in case, if, for example, if there is something as big as the aorta, if there is a disease in the aorta, then there is no vessel, no natural vessel which is as big as the aorta. So you have to use something synthetic. There are many chemicals that is used, chemical, which are the size of the aorta. And as a result, you can remove the diseased part of the aorta and you can use the synthetic vessels. Prognosis. Now, peripheral arterial disease is difficult. It's a long-term disease, very difficult to control. Usually, the patient comes to you with at a very end stage, later stage. Especially if you're a surgeon, you will come when there's nothing else to do. But surgery is not really the answer. We have to advise the patient to go through the exercise, the lifestyle modifications, the dietary modifications. What we mean by dietary modification, meaning less fat, less salt, less sugar. These are the things that are very deadly for a peripheral vascular disease. So dietary modification, lifestyle modification, a bit of exercise, that is what is necessary. We do this and we may be able to revive the patient. If not, then we go into the surgeries, as you have seen the different surgeries that I have shown you just now. And ultimately, if nothing works and the patient is not eager to listen to you, ultimately you'll need to do an amputation of this patient, which is not a good thing for nobody, not for the doctor, not for the patient. You incapacitate this patient for the rest of the life, and there's nothing for this patient to do in the future. So I hope today's lecture was helpful to you guys. Remember, there's a lot of things to study. This is just probably 40% of what you need. There are other diseases, other peripheral vascular diseases, but this is a short study of short understanding. And I think if you listen to this lecture, you have a more introduction to what peripheral vascular disease is all about, and that fear that you have been talking about for a long time. Hopefully that fear has reduced a bit, because you see, you don't need to, at undergrad level, you don't need to have a great lot of knowledge of peripheral vascular disease, just a basic knowledge. And anything you say is okay. And always remember, peripheral vascular disease, if you get a peripheral vascular disease case as a long case in your final prof, it's always a good sign. I have never seen anybody failing with a peripheral vascular disease. You get a peripheral vascular disease and SAR says it's okay, I'll make you pass. You know what I got in my final exam? I got cholecystitis, case of chronic cholecystitis, and I almost failed with that one. So if you get a case of peripheral vascular disease, never get scared. Just what I have said today, I think that is more than enough. Even if you can say 70% of what we have discussed today, I think that would be more than enough to make you pass. If you want to go into in postgrad level, that's something different. I think my vascular colleagues will be better, more educated than me in this case, to give you a better understanding of peripheral vascular diseases. Thank you so much.